Hello, hi. My name is Gracie Han. I'm here to present in the project Predicting Heart Disease using K-nearest means and random forest model. So the goal of this project is to, excuse me, to predict if a person have heart disease or not using variables of interest, mostly heart specific related variables such as chest pain, cholesterol, fasting blood sugar, and thallium induced maximum heart rate, and some ECG factors like ST depression, ST slope, etc. So the database is open database provided by UCI. So here I primarily use the carrot for the modeling, and here are the other libraries of needed. So the data has 400 around the 300 observations and 14 variables of interest. So we look into the distribution of these and then checking missing variables. There's no missing variables in this data set. And for the outcome target, heart disease, yes or no, there's an even split, 54% versus 46%. For these two models, the dummy coding is needed because the original database has only numerical. Even the nominal or categorical ones are coded as numerical, which does not fit. So here are the dummy code. And before any analysis, I'm doing the principal component analysis to see that which variables are mostly influencing the outcome heart disease. Looks like the thallium-induced heart rate is the most one, and followed by exercise, ECG, and chest pain, which is not surprising. So it verifies the clinical knowledge. And next, moving on to visualizing the data. So I looked at the numerical variables and categorical variables separately. Here are the box and whisk plot for numerical as well as the histogram. Actually, all the peak thallium induced are not numerical. Nevertheless, most of the numerical ones, age, cholesterol, are normally distributed, and age, rest blood pressure, cholesterol, there's no difference between people who have heart disease versus not, but the ECG specific or heart disease specific variables, thallium induced, and ST depression do have a difference in people with heart disease versus not, which again confirms the clinical meaning. And then the variables themselves do not seem correlated for the overall population, as well as the looking at the disease versus not disease separately. Here are the visualization for the discrete or categorical variables. I'm not going to explain them one by one, but it looks like that they are confirming our general knowledge, which is men do tend to have more heart disease, and chest pain are chest pain and ECG, rest and exercise-induced ECG do have association with heart disease, at least in the unilateral analysis. So looking at the correlation plot, the variables themselves do not seem to be highly correlated. The biggest correlation is 0.4. So that is a good news, meaning that we can put them independently as put into model. So moving on, before the modeling, we have to do some data pre-processing, and we turn the target variable heart disease into a factor, and also do a split of 80 versus 20% of the data into training and testing. As I said, that the original database have 303, so this training database, which I call EDX, has 242, and then the testing, which is the validation database, has 61. And I want to point out that besides this normal split, because overfitting is such an issue in machine learning, which is commonly observed. So in order for me to validate the results, I did actually a second split among these 244 observations. So again, it's a 80-20. So the second split, I call it test set 2 and train set 2, which has 193 and 49 observations in general. So I just want this to point out. So moving on to the model. The first model is the K nearest means model. I did the tenfold cross validation as well as automated grid search. So here are the results for the tenfold cross validation. The accuracy ranges around the 64% to 66%, and the model chose 5 K nearest means for us. And then the predictions is 62.3 for heart disease. For the automated grid search, here is the list of the accuracy, and here is the plot to visualizing those results. So as we can see that as the K increases from 1 to 100 nearest means, the accuracy goes up and down and then goes back on. It's very interesting that so the looks like the peak K, the peak accuracy is around the 68% at the 30 K nearest means, and the second one is 45 K, and then the third best one is around 10 or 9. So I also, as I said, I did the second data split just to verify the above, and as you can see that the machine learning model on the second training and testing actually produced somewhat different results from the first one. You see that the red line figure is is KNN on the first training and set data split, and then the blue line is on the second one. So from here, the second one looks like the 20K nearest means is the best, which produces 66% of accuracy. So that is very interesting, though, and then also validates that there is need for repeated machine learning training and to validate the trends. So the first that concludes the first model. The second model is the random forest model. Again, I did the first sample split and tried to validate on the second sample split. Here is the function to produce the predicted results. And so I run 100 trees for the random forest, and here are the list, and run the prediction on the testing data, and the accuracy for this random forest is around the 78%, and the model chose 9K, so I used this 9K to produce the ROC curve. the RC curve looks like it's pretty smooth, and the area under curve is around the 80%, which confirms the list of the results. So on the random forest, I produced the risk factors variables of interest. And not surprisingly, the peak ECG stands out as long as the thallium-induced heart rate, which is somewhat in line with the results before all these. Here, just a reminder that these two, although the order is flipped, thallium-induced ECG and the exercise ECG are explaining most of the variables. So the random forest training machine learning model actually tells a similar story, but it flipped the rank of the peak ECG on the most important one, and thallium-induced heart rate as the second one. So as I said, I did the second round of testing and training. As I said, among the total of 303 objects, the first training testing produced 242 versus 49 and 60, and then the second training and testing produces 193 versus 49. So I just want to remind. So here are the second sample, and then actually the accuracy remains similar at 81%. So in summary, the machine learning model can apply to heart health related data. And in this particular database, the random forest performed better than the KNN. The random forest model produces accuracy of around 85%, and the KNN produces accuracies of around 70%. Thank you for your attention.